Good morning, good afternoon. My name is Rafael Villanueva from the Universitat Politécnica de Valencia. In this talk, we are going to explain how to estimate the effectiveness of the influenza vaccine using an epidemiological model and taking into account the data uncertainty. This work has been co-authored by David Martinez Rodriguez, Ana Navarro Quiles, Raúl San Julián, and myself. Influenza is an infectious disease caused by an influenza virus. The symptoms can be mild to severe, and some of them are high fever, running nose, muscle pains, headache, coughing, etc. Influenza spreads around the world in yearly outbreaks, resulting in about 3 to 5 million cases of severe illness and about 500,000 deaths. Due to the high mutation of the virus, every year is like a new disease. A new vaccine must be developed, and a particular influenza vaccine usually confers very limited protection in seasons other than the current one. Anyway, the World Health Organization recommends the influenza vaccine. This organization studies which strains of the virus are most likely to be circulating in the next season, and then allow the pharmaceutical companies to develop the vaccine. This vaccine doesn't include all the strains active in the world during that season, and the companies need 6 months to formulate and produce the required influenza vaccine doses. If the selection of the strains to produce the new vaccine is accurate and there is a good coverage, the vaccination campaign may be effective. As the vaccine should be ready before the outbreak, there is no time to check the vaccine effectiveness, and it is usually done a posteriori. Until now, several techniques have been proposed to determine the effectiveness of the vaccine a posteriori, but their reliability are still under discussion. Most of these proposed techniques are based on a statistical analysis. We propose a technique based on a transmission dynamics epidemiological model. We have data of weekly reported cases of influenza in the season 2016-2017 in the Spanish region of Valencia per million people. The percentage 2.5 and 97.5, that is the 95% confidence intervals, are obtained from binomial distributions describing the data uncertainty and taking into account that the mean of these distributions are the data. We also consider a constant population of 1 million people during the simulation time. Respect to the disease, an individual may be susceptible if it is healthy and not previously infected, infected or infectious when an individual gets sick and might infect others, recovered when an individual gets healthy after sickness, and vaccinated when the people is effectively vaccinated. A susceptible individual might become infected by contact with an infected one. Here, we assume the hypothesis of homogeneous mixing. After a week, the infected individual gets recovered. A certain percentage of the population is vaccinated. This percentage is called coverage. However, the vaccine is only effective in some of them, and these individuals get protected against the influenza virus in the current season. In the expression 1, we can see the nonlinear system of difference equation that describes the transmission dynamics of the influenza disease over the time, where beta of t is the weekly transmission rate to be determined, gamma equal to 1 is the week and infected people needs to be recovered, tau is the vaccine effectiveness to be determined, and also the model returns infected, but the data are reported cases. So we need a scale factor S that multiplying the reported data will approximate the infected returned by the model. The vaccination campaign lasts 14 weeks, from week 4 to week 17, and the global vaccine coverage is 43.55%. Therefore, if we assume an equitable distribution of the vaccinated people per week, we have the expression 2 that determines how the people is vaccinated. Here, we are going to calibrate the model taking into account the data uncertainty. Our goal is to find some sets of model parameter values such that the mean and the confidence interval of the model outputs be as close as possible as the confidence interval of the data. In the graph, in the figure, this means that the blue band corresponding to the confidence interval of the data should be as similar as possible as the red band related with the confidence interval of the model output. To do so, we have to find appropriate sets of model parameter values. A wise strategy is to use an optimization algorithm that find model outputs close or inside the confidence interval of the data. I mean the blue band. We apply several times, in this case 10, the optimization algorithm particle swarm optimization, PSO, performing a total of 50,000 model evaluations. We are going to select the model parameter values among these 50,000. To do that, we use a selection algorithm in order to choose 100 sets of model parameter values in such a way the confidence intervals of the data and the model output will be as similar or as close as possible. The results can be seen in this slide. Black lines represent the 95% confidence interval of the model output of the selected model parameter values. And the colored lines correspond to the 95% confidence interval of the data. As we can see, both groups of lines are very similar. Also, the scale is around 1.27, and this means that the reported cases are around 72%, 83% of the infected people. In this table, we can see the estimation of the vaccine effectiveness. As you can see, it's very low. We compare our results with iMove multicenter case control studies done at primary care and hospitals in whole Europe. In this study, iMove, the team involves more than 100 people in 15 European countries. We can see that our results are not far from the iMove ones, taking into account that we use reported cases in Valencia, and they collect data from primary care and hospitals in the whole Europe. Anyway, both methods confirm the suboptimal performance of the vaccine. The conclusions of this study are: we used a novel computation technique based on a different system model to determine the effectiveness of the influenza vaccine, in this case in the season 2016 and 2017. We used techniques to perform the calibration, taking into account the data uncertainty. The estimated effectiveness of the vaccine is low. In the future, we want to consider age groups because the coverage and the effectiveness change with the age. Thank you very much.